In this short lecture, we'll be going over eye movements, and so that means we'll be talking about cranial nerves 3, 4, and 6, which are the three cranial nerves involved, and we'll also talk about the areas in the brainstem that coordinate how your eyes move together. So first, let's just look at this drawing here that we have the brainstem, and notice that we have the trochlear nucleus as the only cranial nerve here that exits the dorsum of the brainstem. All right, so this has a very long course then from the sort of the back of the midbrain here all the way around to the superior oblique muscle. Then we have the abducens nerve, which also has a very long course that goes out to the lateral rectus. And then we have the third nerve, the oculomotor nucleus, which you can see does a lot more. It supplies superior rectus, medial rectus, inferior oblique, and we'll also discuss that this supplies the main eyelid elevator and also supplies the pupil, right? So 6th nerve palsies, 4th nerve palsies are very straightforward because you're only allowed to have weakness of a single eye muscle. You have a 3rd nerve palsy, there's just a lot more going on. Okay, so the easy way to remember this is superior oblique, supplied by the 4th nerve, lateral rectus by the 6th nerve. All of the other extraocular muscles are supplied by cranial nerve 3. So here is a drawing showing you the pull of the individual eye muscles. Medial and lateral rectus is very easy. Medial rectus pulls the eye towards the nose, lateral rectus pulls the eye out. This is rather complicated here with these other 4 extraocular muscles. The tendency of the superior oblique is to pull the eye down towards the nose. Inferior oblique is up towards the nose. Superior rectus is up and out. Inferior rectus is down and out. The reason I say this is complicated is because as you are looking around, you're looking to the right, looking to the left, there's tension of all of these muscles, and so they don't act purely to elevate or depress, but they act to twist. So for example, a twisting motion of the eye towards the nose we call encyclotorsion. A twisting movement of the eye out, sort of down and out, we would call excyclotorsion. All right, so but this is still a good general rule here. Again, lateral rectus, medial rectus, very easy, superior oblique, inferior oblique, and the superior and inferior rectus muscles like this. All right, so this drawing illustrates the individual eye muscles. Let's start with the superior oblique, which is the one that often has the most controversy because it's frequently described incorrectly in review books. So I want to make sure that we get this right. So here's the superior oblique muscle. And notice with each of these there is a star which indicates this is the strongest action of this muscle. And so the strongest action of the superior oblique is when your eye is looking towards your nose and then it acts purely for depression. Okay, so we're looking on top of the right eye, and so notice the eye is looking in towards the nose, and as the eye moves in, this muscle becomes very tight, and so if we just imagine pulling here on the superior oblique, the eye is purely depression down and towards the nose. Okay, so notice though that we kind of have to remember we're looking on top of the right eye, and the nose is here, the nose is here, the nose is here, okay? So as the eye, though, is in the abducted position, so now we're looking to the right in this eye, when the eye is in that position, the superior oblique acts to encyclotort. So remember, that is a twisting motion down towards the nose. So the right eye is looking way off to the right, let's say, but in that position, you need to be able to twist your eye, to rotate it in that direction if you're going to track something, for example. So all of these muscles have a torsional action as well. Okay, and I'm going to show you an illustration here in just a little bit. So notice the superior rectus. We said from the previous slide, the superior rectus, you want to think of that as mainly looking up and out. Okay, so the strongest action, again, we're looking on top of the right eye, is when the eye is looking out, the superior rectus is very strong to elevate your eye. Okay, but as your eye, if you're looking around and you're looking now towards the left, then the superior rectus has a function to encyclotort the eye. Okay, so notice that encyclotorsion of the superior rectus is when the eye is looking towards the nose. Encyclotorsion of the superior oblique is when the eye is looking out. Now for the inferior muscles here, you need to imagine we're looking on the undersurface of the eyeball, so we're kind of looking up at the right eye. So the inferior rectus, its strongest action is when the eye is in the abducted position. We know the inferior rectus wants to depress the eye when the eye is in the abducted position. Okay, so its action is purely for depression. Okay, but when the eye is in the adducted position, it acts to excyclotort, sort of a twisting movement out. The inferior oblique, okay, again from our slide, we know this is up, but it's up when the eye is looking towards the nose. Again, we're looking on the undersurface of the eye now, so when the eye is in the adducted position, it works strongly to elevate the eye. Okay, as the eye is abducted, it acts to excyclotort. And so just imagine, I would just encourage you, pause the video, look in the mirror, and just fixate and twist your head all around. And you will see the excyclotorsion, the encyclotorsion movements of both eyes as you twist your head around and fixate on something. So in a third nerve palsy, what is working in a third nerve palsy? Well, 4 and 6 are working. And so this patient has a right third nerve palsy, so the lateral rectus is working, but it's unopposed. The medial rectus is supplied by the third nerve, which is not working. So the lateral rectus pulls the eye out, okay, and then the eye tends to get pulled down a little bit. The third nerve also supplies the levator palpebra, which is the major eyelid elevator, so there's ptosis. And typically in a third nerve palsy, the ptosis is more severe than this. I asked the student not to draw it completely because I wanted you to see the position of the eye, but more realistically, real world, this eye is going to be almost completely closed. And you as the examiner have to come along and lift up the eyelid to even see the position of the pupil. The other thing you'll notice in a third nerve palsy is that, remember the parasympathetic fibers we talked about just a little bit ago that constrict the pupil. Now we have unopposed sympathetic stimulation of the pupil, and so the pupil is dilated. So in a third nerve palsy, the eye is down and out, and we have ptosis and mydriasis, a large pupil. So causes that you know of so far are uncal herniation and a posterior communicating artery aneurysm. So remember, these are patients in a coma that have uncal herniation. PCOM aneurysm is a severe headache, and we will, as the course goes on, we'll add these 3, and I'll explain what these look like later. Each of these, if you know these 5 causes of third nerve palsy, I think you're in good shape for this level of training and for boards. And fortunately, each of these have unique clinical presentations. Now in a 6th nerve palsy, so you're losing the abduction of the involved eye, and so notice that when the patient is just looking straight ahead, we call this primary gaze, you might not notice too much, okay? But if you look carefully, this eye is turned in just a little bit, okay? And that's because we don't have the 6th nerve functioning here, so the medial rectus is a little stronger. So there is a little bit of a disconjugate gaze. They're not lined up correctly, but we really notice it now when the patient looks to the right, and this right eye cannot abduct. So in whether the patient's looking up to the right or down to the right, it's going to become very prominent in a 6th nerve palsy when they look to the side of the lesion. Notice though when they look in the other direction, man, this looks pretty good. And that's because in the right eye, when you're looking to the left, it's the medial rectus that needs to be working, and that's going to be normal in a sixth nerve palsy. Now, a bilateral sixth nerve palsy is a very concerning finding because this indicates frequently that the patient has increased intracranial pressure. So tumor, hemorrhage, something bad. And that increased pressure tends to stretch and damage both sixth nerves. And so if you just have the patient look straight ahead, you might not notice much. But notice when they look to the right, this eye is not abducting. So the patient has a right sixth nerve palsy. And when the patient looks to the left eye is not abducting. So if we see a patient with a bilateral sixth nerve palsy, we need to do an urgent brain scan typically to look for what's causing the increased intracranial pressure. Now, a fourth nerve palsy is very interesting because patients will walk around with their head tilted in the opposite direction because that's how they can line up the eye muscles. So here's a child with a fourth nerve palsy, and this child is probably always going to have his head tilted to the right because notice the eyes are conjugate. Okay, but what you notice here, the child tries to look over here at something, and remember, what does the fourth nerve do when the eye is in the adducted position? It depresses the eye. So in looking this direction, this eye, it doesn't get pulled down, it gets pulled up. Okay, so it becomes disconjugate in that position. Okay, and what we really like to do to bring out a sixth nerve palsy is have the patient tilt the head in the direction of the fourth nerve, because when you tilt your head to the left in this case, and just kind of imagine you're tilting your head to the left, so your head is going this way. So for your eyes to fixate on something, when you tilt your head to the left, you need this left eye to encyclotort, like this. Okay? And remember, that's the function of the fourth nerve as the eye becomes more in the abducted position. So tilting your head towards the side of the lesion now makes the eyes appear very disconjugate in that position. All right? And so you can look at these slides here, which just kind of show all of the primary textbooks indicating what I said about the function of the superior oblique. It's depression when the eye is towards the nose. It's encyclotorsion when the eye is in the abducted position. And I only include this because a lot of review books seem to suggest that the superior oblique its primary function is down and out, which is not correct. Right, so here's a woman, had a car accident, and complains of vertical diplopia. Diplopia is double vision. Vertical means the images are kind of one on top of the other. Now, looking straight ahead, you might not notice too much, okay, which is common with the fourth nerve palsy. Notice when she looks to the right, remember when the eye is in the adducted position, that's when the superior oblique normally wants to tug the eye down a little bit. And so when she looks to the right, she's kind of looking down at something here. This eye, whoop, it goes up. When she looks to the left, again, this eye is a little bit, we call this a hyperopia, which means the eye is just a little bit more elevated than the other eye. Still hyperopia here, she looks up, and we're just losing a little bit of the down pull from the superior oblique lesion. Again, this eye is still a little bit elevated. But notice when she turns her head to the right, so she's got a left fourth nerve palsy, and this is why patients want to tilt their head to the opposite direction. Okay, because when you do that, again, look in the mirror and see what are your eyes doing when you fixate on the mirror and you tilt your head to the right. The head is going this way, so to maintain fixation, this eye needs to encyclotort. This eye needs to excyclotort. All right, and so that's why tilting your head to the opposite direction is the best position for these patients. And so when I have someone that I think has a fourth nerve palsy, oftentimes they don't know when it started. And so if they have photos on their phone they can show me, I'm usually going to see in every photo their head is tilted just a little bit. And then you can kind of go back and see when their head wasn't tilted, and sometimes that can help you time the onset of when this occurred. I saw a medical student years ago who has always tended to tilt his head in one direction, and he actually had a really subtle fourth nerve palsy for most of his life. Now notice when she tilts her head to the left, okay, and to fixate on something when you tilt your head to the left, now is when you need this eye to encyclotort. And so you're losing the function of the fourth nerve. And so that's why to really bring out a fourth nerve palsy, you need to have the patient tilt their head from one shoulder to the other, and that makes this really obvious. Okay, so when we do our brainstem section, I'll show you this slide, but here's the fourth nerve as the only cranial nerve that exits the dorsum of the brainstem. So it travels a long route. It's a very thin nerve, and therefore very susceptible. For example, if someone's in a car accident, you can easily damage that nerve. Okay, and remember when we look for the fourth nerve in our brain dissection, here's the cerebral peduncle, here's the fourth nerve kind of wrapping around the cerebral peduncle on its way out to the superior oblique. Now let's just briefly go over areas in the brainstem and brain that help to coordinate eye movements. And we're going to talk about 3 types of conjugate eye movements. Conjugate just means your eyes are moving together, tracking together. We have 2 that fixate the image on a retina. Okay, so we have the vestibular ocular reflex and visual pursuit. And then we have one that redirects the line of sight. And we can illustrate all of these by just imagining you're on a train and you're tracking something, a tree or whatever, as you're on the train. So that's going to be visual pursuit. Okay, but then your eyes want to catch up to something else that is ahead, and that would be a saccade. A saccade is a quick eye movement. The vestibular ocular reflex is something we utilize every millisecond of our entire life. Anytime you move your head, you walk, your eyes are always moving appropriately. You know, like if you're bouncing up and down, if we didn't have the vestibular ocular reflex, everything would feel like it's just jiggling around. If you've watched any of those old cops videos where some poor person is with a camera following around after police is chasing someone, everything kind of bounces up and down dramatically. And that's what life would be like for us if we didn't have a vestibular ocular reflex. Okay, so just if you notice, if you move your head to the right, what do the eyes automatically do? They go to the left. All right, and so this is the vestibular ocular reflex. And so this is a very complicated drawing because we haven't talked about any of this anatomy yet. So don't worry about this drawing. You should come back to it later. I mainly just want to illustrate one thing. Let's imagine here we're looking on top of the eyes. Okay, and what happens? Again, just look in the mirror and turn your head to the left. What do your eyes do? They go to the right. Okay, how does that happen? Well, when you turn your head to the left, in the inner ear, this stimulates a flow of endolymph in the semicircular canals. Okay, and this movement is very precise. It goes into brainstem pathways that we'll talk about here in just a little bit. And so if you move your head to the left, you want your eyes to go to the right. So what eye muscles need to be activated to move your head to the right? Well, in the right eye, you need the 6th nerve in the lateral rectus. This moves your right eye to the right. And in the left eye, you need the 3rd nerve in the medial rectus, which moves your left eye to the right. So again, you move your head to the left, fluid is moving in the semicircular canals, which through this complex mechanism activates these 2 appropriate eye muscles so that your eyes move to the right. And this is a very powerful reflex. So we might check this in patients. It's called the oculocephalic, or sometimes called the doll's eyes reflex. Well, we'll have the patient quickly turn their head to the right, and if the patient is still able to maintain fixation, then we would say this is an intact and normal oculocephalic reflex. Later we will talk about another way to stimulate this pathway is through cold calorics, where we irrigate the ear with cold water, ice water, and that has an effect to stimulate flow here in the semicircular canals. Now, these next few slides are really important. This will be repeated probably 10 times throughout the course, and so this is not something to gloss over. Make sure you get this, because you will either get a lot of questions right by understanding this, or you will miss a lot of questions. All right, so the saccadic pathway is really important for figuring out a lot of things that happen clinically in neurology. So here's the big picture. The left hemisphere of your brain, and I'll just have you label this here. We called this earlier the frontal eye fields. It's right here. The left hemisphere of your brain is always wanting to move your eyes to the right. The right hemisphere is always wanting to move your eyes to the left. So here's how it does this. So remember, the left frontal eye fields want to move your eyes to the right. And it does this by activating an area in your pons called the PPRF, which is the paramedian pontine reticular formation. Think of this as the horizontal gaze center. And this is intimately part of the sixth nerve nucleus. In fact, we call this the PPRF sixth nerve complex. Okay? And so this first pathway then activates the sixth nerve, which is going to move the right eye to the right. Okay, so we've accomplished half of our goal. We want both eyes to go to the right, but here at least we've activated the right lateral rectus. The right eye moves out. Okay, and what the PPRF does is it generates a pathway, a very important, clinically important pathway called the medial longitudinal fasciculus. And the medial longitudinal fasciculus, its job is to allow the PPRF to activate just the part of the third nerve nucleus that supplies the medial rectus. Okay, and so therefore this then can drive the left eye to the right. Okay, so that's how you were able to quickly move your eyes to the right through this pathway. Now I drew another pathway that has nothing to do with eye movements, just because we can now make some clinical applications. And here is the corticospinal tract, okay, which crosses here in the lower medulla. And so remember, this is moving the right side of your body. Okay, so now let's make some clinical applications of this. But first I just wanted to make a point of these different eye movements we've been talking about. What is the strongest? And to prove that to yourself, I want you to do something. I want you to take your whole hand and just put it in front of your eyes. And I want you to move your hand back and forth. And start moving your hand back and forth and just track it with your eyes as your hand goes back and forth. And now I want you to start moving your hand faster and faster and faster, and eventually it just becomes a blur. Okay, now I want you to hold your hand in front of your eyes and move your head back and forth. And now move your head faster and faster and faster. And notice you're able to maintain fixation really well. Okay, so this is just to illustrate how strong the vestibular ocular reflex is. And also, when we have a problem with the vestibular ocular reflex, as we'll discuss later in the dizzy lecture, these patients often have profound vertigo and balance problems because we really rely on this working perfectly. Okay, so let's finish up here just making some clinical applications. Let's say that someone has a left middle cerebral artery stroke. Okay, now we've already said that the corticospinal tract will be affected here, and so patient will have weakness on the opposite side of the body. Okay, and so which way will the eyes tend to look if we have a stroke here in the left middle cerebral artery? Well, if you didn't even understand or remember all of this, if you just remembered that the left brain normally wants to drive the eyes to the right, okay, and so if you destroy this area, now you have the frontal eye fields in the right hemisphere that are overactive, and they're going to drive the eyes to the left. So remember, the left frontal eye fields want to drive the eyes to the right, and so if we have a stroke here, the eyes can't go to the right, and so they get driven towards the left. Okay, and so hemiplegia is just weakness on one side of the body. So in this case, if we have a left MCA stroke, here as the patient is sort of looking at the screen, the right arm and leg are weak, and the eyes get driven to the left. So the eyes look away from the hemiplegia in a middle cerebral artery stroke. Now let's keep the same drawing, and so let's put the stroke now in the right pons. Okay, here's our corticospinal tract, now coming from the other side. So if we have a stroke in the right pons, which side of the body will be weak? It's going to be the left arm and leg. And now which way will the eyes deviate? Well, what does the right pons normally want to do? It wants to drive your eyes to the right. So if you destroy a part of the brain that wants to drive your eyes to the right, well, guess what? We've got a PPRF6 over here that is now overactive, and so the eyes get driven to the left in a right pontine stroke. The left side of the body is weak, the eyes look to the left, and so now we can see with a pontine stroke, the eyes look at the hemiplegia. Okay, so this can be really helpful. You have a patient come in with a stroke in the emergency room, and one side of the body is weak, and so you just want to know which way are the eyes looking. The eyes are looking at the hemiplegia. Okay, this is a pontine stroke. Eyes looking away from the hemiplegia. It's a middle cerebral artery stroke. And this is just very practical to know because our workup for that patient is going to be different depending on the vascular territory that's involved. All right, and then tomorrow I'll show you some videos of this. But what happens if we have an isolated lesion here of the medial longitudinal fasciculus? And this is something that in young people most often occurs due to demyelination from multiple sclerosis, although it can also occur with a stroke. So let's say we have a left medial longitudinal fasciculus lesion. And so remember, what's the only function of that pathway? It's to move your left eye to the right. And so at baseline, the eyes look pretty conjugate. When the patient looks to the left, no problem. Okay, but when trying to look to the right, now the left eye, patient's now trying to look to the right, the left eye isn't able to move towards the nose. Now the brain sees that as double vision, which it doesn't like. It tries to bring the images together, and so we usually get a little nystagmus here in the normal eye. And you can, if you don't know what you're looking at, you'll think, wow, look at the nystagmus in that eye. This is the normal eye. It's just trying to bring the images together. Okay, so in fact, if you ever see nystagmus in one eye, the most common cause is an MLF lesion. And so this is called an internuclear ophthalmoplegia. Ophthalmoplegia, big word for an eye movement problem. It's intranuclear because this MLF pathway is between these nuclear groups. So if you see this in a young person, you can be very confident that they have multiple sclerosis.